Hi, can you hear me? Okay. I want to welcome everyone. In response to the evolving COVID-19 pandemic, we have launched this bi-weekly virtual learning community for the Mountain States to address COVID-19 management issues in our region. We welcome you all to session 2 today and invite you to forward the registration link to other colleagues you think would be interested in attending. Today, our speakers will be covering the pulmonary pathophysiology and respiratory management of COVID-19. Our topics will change every session, so please come back for continued learning opportunities. We welcome suggestions for future topics, comments, and opportunities to better serve this group. Please feel free to send communications about the series by email or in the chat box to Victoria Myers, who is facilitating this session. We also encourage you to enter questions about the presentation into the chat box for us to address during the Q&A session at the end of the presentation. So sometimes we forget our questions. Please go ahead and enter them and we will get to them at the end. Before we get started, we want to acknowledge that this is a joint collaboration between the National Emerging Special Pathogens Training Education Center, NETEC, and Denver Health, Denver Prevention Training Center, and Robert Wood Johnson Foundation. This is also in collaboration with Project ECHO. My name is Karen Wendell. I'm one of your facilitators today, and I'm an infectious disease physician at Denver Public Health. Today's agenda will include a tech check with Victoria Myers, 2 short presentations from our experts of the day, Joseph Hippensteel, our pulmonologist and critical care physician joining us from University of Colorado, and Anna Neumeier, who is a pulmonary and critical care physician, also faculty at University of Colorado, but practicing at Denver Health. And finally, we will wrap up the session, as I said, with a Q&A session. So please feel free to keep track of those questions for us. Victoria, I'm going to turn it over to you.
Thank you, Karen. Good morning, everybody. So I'm Victoria Myers. And just to let you all know, we will be recording this session and we will upload it so you all are able to go back and review it at your leisure. But a few things to point out with our technology. You have the option to have your camera on or off. We would love for it to be on, of course. I mentioned that earlier. So down in the lower left of your screen, you will see either start video if you were on, or if you were off video, and stop video if you were on. Right next to that is your microphone. Please feel free to use that when we go to the Q&A session. You're able to unmute and ask your question. Of course, you're allowed to put it in the chat as well. So to make sure everyone knows where the chat box is, I've just put in there Inglewood, Colorado. That is where I'm calling in from. So if everyone could put in the chat box where you are calling in from, it's also nice for our presenters and our staff to know where everybody kind of is to help with some of the resources that we'll be talking about. You're able to rename yourself if you need to. We do love first and last name for attendance. You can just click on your little video box with the 3 dots and hit rename. And with that, I will turn it back over to Karen after I put in our website where we will have all of our resources. Just as a reminder for you all, that's where you can access everything after our sessions are finished.
Thanks, Victoria. So we're going to start with Joseph Hippensteel. He is an instructor at the Division of Pulmonary Sciences and Critical Care Medicine at the University of Colorado, and he'll be discussing pulmonary pathophysiology of COVID-19. Thank you, Joseph.
All right, well, thank you for having me today. I'm really excited to share my thoughts on COVID and what I know of the pathophysiology, really from some really great or excellent reviews that I found. So just make sure y'all can see this and not seeing my presenting view, it sounds like we're good to go. So again, I'm Joe Hippensteel. I'm from the University of Colorado. I've seen a lot of folks with COVID-19 at this point. I think around 1,000 patients have come, maybe 2,000 patients have come through our hospital. I have no disclosures, no conflicts of interest. I do mention some treatments, which I have no vested interest in. So I just throw that out there right up front. So this is what I'm going to talk about today. I'm going to give you all a quick overview of what the SARS-CoV-2 virus looks like. I'm going to talk about how the virus gets in the body, what our body does to try to fight it, what can go wrong, a few clinical correlates. This is really more sort of that basic side of things, but we'll talk about sort of clinically how this is relevant, and then what we know so far about what happens in folks who have died from the disease. And just to simplify this a little bit, I'm going to talk about what is SARS-CoV-2, how it's transmitted. Some people sort of jump out at this point and recover without ever developing symptoms. How does our body respond typically? And again, some people recover then. what occurs in severe infection, which Anna will be talking more about in terms of how you manage this disease, and then what do we find in the organs of patients who have died. These are two really good papers. So if you take out your phone, this is going to be at the end as well. Just take pictures of these and you'll be able to pull up the main papers that I used as resources. So this is the Q code, just feel free to scan it and we'll be able to dig a little bit deeper than what I've shown here. So a case, so we have a Mr. Z, who's a 62-year-old man who went to a party, and unfortunately COVID was circulating, it was indoors, and this ended up being a problem for him, as you'll find out in this case presentation. So I want to start off talking about the virus itself, the SARS-CoV-2. And this was first described back in January, first popped up back in December in Wuhan, China. The coronavirus disease, which is called COVID-19, is caused by the SARS-CoV-2 virus. This is the first electron micrograph of that virus. Then you see the virus particles down in cells down in the bottom right. There have been now more than 35 million cases and just about 8 million cases in the US or slightly less. The range of illness is from severe to asymptomatic, as I've already mentioned, but we think about 5% of cases will end up in the ICU, potentially a few less. And of those who end up in the ICU, the mortality rates at our hospital have been about 20% for the ICU patients. And I think across the world, you've seen ranges from 20 to 95%, depending on the case series. And this is the virus itself. So there's the spike protein, which we've all heard a lot about. There's a single strand of RNA, which gets into cells and gets basically transcribed so that this virus can replicate. And then there's a variety of other proteins, so 3 other proteins and then a lipid membrane. So this thing floats around both in the air and gets into our body. So Mr. Z, a couple days later, for a few days, he was feeling fine, and then he develops a mild cough and a fever. And so what I want to talk about here is viral transmission and how this virus actually gets in to the host. So this is what we call viral entry. Here it's a physiologic response. So this is pretty normal for a virus. So not something that's atypical. And we actually know a lot about this process. And so this happens, one patient's coughing, talking, and patient 2 gets the virus. It's primarily transmitted, again, through talking, coughing, sneezing, sort of large droplets in the air. Exposures of greater than 15 minutes and within 6 feet of a sick patient are the highest risk. But we do know that it lives on surfaces. I think I saw a report yesterday that it can live for 28 days on elevator buttons, on doorknobs. Whether that's true, we're not totally sure. And then aerosolization, so things like BiPAP and CPAP and intubation, probably a little less risky, but we still take super precautions at the University of Colorado and elsewhere. But certainly droplets are the biggest. So wearing a mask for that patient is probably the most valuable thing we can do. The virus then gets into the nose, which then subsequently gets into the lungs. And I point out here these type 2 cells, which are sort of our regenerative cells in the lungs. These are the main cells that it initially infects. Once it gets into the body and towards these cells, I bring up the spike protein again. So the spike protein is on the outside of that virus. That spike protein interacts with heparin sulfate, which is dear to my heart because that's what I study. And then the ACE2 protein, which you've all heard of because of ACE inhibitors, but it basically gloms onto the cell because of those 2 molecules, and that's been really well established. And then this TMPRSS2, the serine protease, basically cuts the spike protein, activating the virus, and then the virus gets into the cell and it's internalized. And so that's the process, really well established that this is what happens, very sort of interesting pathophysiology. Once the virus is inside, the RNA sort of breaks loose, it replicates and cells die. And so this is where we start seeing fevers. And this is when people start to get sick. These are some other organs that have ACE2, just to throw it out there. We don't totally know that all of these organs get infected, but the thought is that they're potential organs that can be infected because of ACE2 being on the cell surface. So we go on, in our case, Mr. Z, now we know a little bit more because he's now come to clinic. He has hypertension, diabetes, and obesity, which I'll get into later why that's important. He goes to urgent care and he's found to have the following vitals. So he's febrile to 38.4. He has a saturation of 94% on room air. He ends up being told, you're doing okay, go home, self-quarantine, take some Tylenol for your fever. And so this is the host defense. So his body is starting to fight this infection. That's what I want to get into next. Here's a nice little pictorial of what's happening. So this is a patient who gets better in theory, and this is our physiologic response. So basically this virus gets into the cell, the RNA breaks loose, virus replicates, cells break up, and you get these ghosts and monsters that are released. And what we call these ghosts and monsters are DAMPs and PAMPs, or damage-associated molecular patterns or pathogen-associated molecular patterns. And our body recognizes these. And what happens is we put out inflammatory mediators, we put out cytokines, we put out antiviral particles like interferon. And these are some of the ones that have been found, but there's obviously a vast number of others if you look in the literature. This is where tocilizumab might be valuable, although that hasn't totally borne out. So this is an anti-IL-6 antibody, which may dampen this inflammatory storm. From there, inflammatory cells are recruited. My little Pac-Man up in the top right, which I don't know if it's copyrighted, but I made this. T cells are really important, it seems. We have dendritic cells, macrophages, and neutrophils, which get into that tissue. And here you could think steroids might be beneficial. So if we give steroids, we might be able to quell this inflammatory cascade. And then at between 7 and 14 days, we develop antibodies, which are targeted to this virus. And the spike protein antibodies are probably the most valuable, but we're not totally sure on this. This is all, I think, still speculative. There may be more data in the last month or two, but as of August, we didn't have great clarity as to what was happening. That said, we are using convalescent plasma as a trial. And then there are other antibody products. So the Regeneron antibody product that President Trump got was one of these antibody cocktails to try to fight this disease. So at this point, what ideally happens is these antibodies and these cells and these cytokines all work together, and they clear the virus and they clear the DAMPs and the PAMPs, and patients get better. Unfortunately, we know that a lot of patients don't. So about 20% of patients end up in the hospital. So Mr. Z sort of went down this path. He, again, has some comorbidities. He returns to the emergency room because he's just feeling worse. He has fever, and he has an oxygen saturation that's now 83%, and he's on 3 liters per minute of oxygen. And so at this point, although the previous stuff has been pathophysiology too, I really want to talk about what can go wrong. And so here you'll see this is where we're getting into this hyperinflammatory phase or this negative phase. And you see that this virus is ramping up and our body's response is ramping up. And so this is sort of an aberrant response, aberrant regulation to this COVID virus. And I'm going to walk through different pathophysiologies, different components that we think play a role. The first one, cytokine storm, which we've all heard about. Cytokine storm happens with chemotherapies, which we talk about when people are getting chemotherapy for different diseases. But what happens in this disease is those inflammatory mediators that I talk about get released, inflammatory cells come in, and it basically leads to a feed-forward cycle or a positive feedback cycle, and this really gets out of control. I had mentioned before that we can use tocilizumab. There are other antibodies that were used. There are steroids as well that can sort of dampen this. That might be helpful. Again, I'm not getting into a lot of management here, but I think of these 2 steroids is probably the most valuable for somebody who's hypoxic, and Anna may touch on that later. The next is you can imagine that these cells, these inflammatory cells, are putting out all sorts of mediators to kill this virus and to fight whatever is present. And so they put out reactive oxygen species, hydrogen peroxide type things. And they put out proteases like that serine protease that actually the virus uses. And those proteases and those reactive oxygen species cause local damage to the lung and wherever else this virus tends to go. The next, there's some question as to whether some of these antibodies are actually negative. This is not proven. It's just a thought that because very sick patients end up with higher levels of antibody titers, it's possible that they're basically interacting with this virus and allowing it, doing something to facilitate the virus's entry into cells potentially, or causing more harm than good in some patients. But that's, again, more speculative, not absolutely proven. The fourth, and I think this is more of a clinical paradigm, which we don't completely understand, is a coagulopathy. And this has been recognized since the beginning of the disease. I think even in March, in February, when these cases were ramping up in China, they noticed that DIC was common in patients who died. So I think they reported that 90% of patients who died ended up with criteria that met DIC criteria. What to do with that? Support the patient. There are a lot of autopsy reports of fibrin-rich microthrombi, so little clots that develop in the lungs, which seem to be a problem. But again, we don't know what to do with that. There's some groups that think that there's problems with that fibrin getting stuck and not breaking up. So maybe fibrinolytics might be helpful, which is being studied at Denver Health and the University of Colorado. And then there's a huge prevalence of venous thromboembolism. My wife actually went to the doctor the other day. Anna, this is news. She's having a baby, but she was told that she'd be put on Lobinox if she ended up with COVID-19. So the thought is that there's a high prevalence of thromboembolism, both PEs as well as clots in other parts of the body. So about a quarter of patients in the ICU will end up with clots, maybe higher. In ECMO, I think the rates end up being about 75%, at least in our hospital. And so anticoagulation is another therapy that might be beneficial, which is being studied. It has not been proven. The unfortunate thing is that bleeding is also common. So a lot of folks are developing sort of spontaneous bleeds, either on anticoagulation, less so I'd say off anticoagulation, but we have to have equipoise in this realm because we're not sure of the risks and benefits to patients. And then the last thing, which is sort of the overarching pathophysiology of COVID-19 in the lungs, which looks a heck of a lot like ARDS. For those patients who develop severe disease, they develop the hyaline membranes, they develop neutrophil and lymphocyte influxes into their lungs, and they get this thickened interstitium, and they look a heck of a lot like ARDS, like I mentioned. And so here we're at this hyperinflammatory phase. We have ARDS, and what happens is you end up with multi-organ dysfunction, like other patients with ARDS. COVID-19 may have some more targeted effects as well. But so Mr. Z, unfortunately, continues to get worse. His oxygen saturations drop in the hospital on multiple occasions. He's transferred to the ICU, and quickly he ends up intubated, quickly proned, which I think many of our patients end up proned, which Anna will talk more about. And so I want to talk really briefly about clinical correlates. Here we have epithelial and endothelial damage. So the alveoli themselves get damaged. The blood vessels are damaged. This leads to non-cardiogenic pulmonary edema, which is essentially ARDS. This looks like ground glass throughout the CT or chest x-ray. Patients develop hypoxia. And then again, because those type 2 pneumocytes are particularly affected, the thought is maybe that leads to a problem with repair. There are a couple high-risk groups that I want to point out, and this gentleman has a few of them. So older age, typically we think about 70 years old or above. There's a high risk of mortality. Comorbidities seem to be a problem. And then there's this propensity for lower income patients and minority patients to have very severe disease or die from this disease. The thoughts for why older age might be a problem is epithelial repair. So they maybe have less type 2 pneumocytes, for example. They have less ability to regenerate. Endothelial damage that's pre-existing might be a problem. So hypertension and diabetes may be the reason for that. And then for why these disparities exist, we really don't know, but one thought is maybe an increased inoculum because of sort of closer quarters, less access to care. We're really not sure here, and there's probably some genetic component to this as well, which we're just not sure of. There may be more data since what I found, but that's sort of what we know so far. And so unfortunately, Mr. Z, he has a 22-day hospital course. He's proned for many days. His family decides that they want to withdraw care because our next step would be tracheostomy and PEG placement, which is pretty common in these patients. He's transitioned to comfort care and he passes shortly thereafter. And so what do we know about patients who die? So autopsies of COVID-19 are actually fairly sparse, surprisingly. These are two pretty big case series of 10 patients each. And what they found, and what I really want to point out here, is it looks like ARDS in the lungs. So they have diffuse alveolar damage, which is what you see pathologically in ARDS. Some patients have what looks like organizing pneumonia for the pulmonologists who are in the room, which is neither here nor there for the rest of you. A lot of pulmonary thrombi. They see the CD8 T cell depletion. They see acute tubular necrosis for those patients who have AKIs. And then a lot of other odd findings, which if you look at the New England Journal, there's case reports every day of new things that are popping up. But these are some of the findings that they found in these patients specifically. In the lungs, again, looks like ARDS. So you have diffuse alveolar damage, you have hyaline membrane formation, and you have this inflammatory infiltrate, which are neutrophils, and then again, lymphocytes, which is a little atypical than some other diseases of ARDS. But again, looks a heck of a lot like ARDS in the lungs. And so with that, again, pull up your phones if you're interested in reading more. This will give you some more background about COVID-19 in the lungs. So I'll give this just a second and then I'll let Anna take over. And sorry for divulging about having a child, but what can I do? Thought it was pertinent to the talk. Okay, and with that, I will stop sharing. I can put this back up if people have questions later on during the question and answer section.
Okay, thank you so much. We're now going to transition over to our next speaker. And I want to thank Joseph for a great talk, congratulate him on the baby coming, and also thank him for having some Halloween themed slides with his ghosts and other Halloween imagery. And I want to introduce Anna Neumeier, who is our next presenter. She is an assistant professor at the Division of Pulmonary Science and Critical Medicine and works at Denver Health and Hospital Authority. And Anna will be talking to us about respiratory management of patients with COVID-19. I'll turn it over to Anna.
Thank you so much. And Joe, congratulations. That's so exciting. So for this talk, I'll be discussing the goals of oxygen supplementation in patients who have COVID, discuss the respiratory management of the non-intubated patient, and then we'll spend some time explaining the approach to the respiratory management of the patient who's intubated, who likely has acute respiratory distress syndrome, discussing lung protective ventilation, prone positioning, and how you might approach management of refractory hypoxemia and when to consider ECMO. And I think the goal of this talk is to reiterate the evidence that we have for the management of ARDS, because although COVID is a new disease, ARDS is not, and we actually have tremendous evidence that guides our best practices. And so we have the opportunity to apply 20, 30 years of research to the management of this disease to support our patients. So we'll do a case-based presentation and we'll have a couple of polls for you all to participate. So this is a case of a woman I cared for maybe back in May. So she's a 54-year-old woman. She has diabetes, hypertension, presented with fever, malaise, dyspnea for 10 days. On admission, she's tachycardic, she's hypoxemic, she's tachypnic. She has a leukopenia, elevated ferritin, high fibrinogen. Her COVID is positive. So if you're seeing her in the hospital, what would be your next steps? And to remind you, she's 80% on room air. So would you give her oxygen via nasal cannula to titrate to a sat greater than 94%? Are you going to titrate to a saturation greater than 90%? Or is greater than 88% sufficient for this patient?
We've got about 34% of people who have answered. We'll give it maybe another 15 seconds. You're halfway there. And if it's not showing on your screen for any reason, you're welcome to type your answer into the chat.
All right, so greater than 90% is the majority of the answers. Okay, thank you so much. So I want to talk about kind of this idea of demystifying the happy hypoxic, because for many of you that might have seen on social media, there's a lot of posts of patients that look quite comfortable with very, very low saturation. And in reality, physiologically, we actually distinguish between hypoxia, which is inadequate tissue oxygenation, from hypoxemia, which is low blood oxygen. So you can be a happy hypoxemic, but you cannot be a happy hypoxic. And so it relates to this idea of your oxygen extraction ratio, which is the description between your body's oxygen consumption, which we measure by the VO2, and the systemic oxygen delivery, which is your measured, known as your DO2. In reality, our normal state, our oxygen extraction ratio is 25%, meaning we have plenty of oxygen delivery for what we need to consume. But when someone gets sick and when they have high metabolic rates, and if they have impaired oxygen delivery, perhaps because their lungs are ill or they are in shock, that ratio will change significantly. And once that oxygen delivery is insufficient, then you will start to develop hypoxia, which leads to cell death. And so when you're thinking about oxygen saturation or goals that you're measuring, you really want to think about, is the oxygen I'm prescribing providing adequate? What is this patient's mental status? What is their work of breathing? If they have a very high work of breathing, they're not getting adequate oxygen. What's their lactate? And do they have evidence of end organ damage? And that's going to be individualized across a patient. If someone has severe peripheral vascular disease, coronary artery disease, perhaps intestinal ischemic disease, they're going to need a higher oxygen level than someone who's otherwise healthy. And so based on that, the WHO guidelines actually recommend that during the initial resuscitation of a patient with COVID, you should titrate greater to 94% actually, and then greater than 90% for maintenance. And so really, unless someone is comfortable, you really want to avoid kind of these lower saturations. So what happens when someone has increased work of breathing? So they increase their inspiratory flow rate and they increase their minute ventilation. As someone has a higher inspiratory flow rate, they are having a larger fraction of ambient air that's being introduced with every breath. So it's diluting the oxygen that you're giving them. And so it depletes the reservoir, and consequently the fraction of FiO2 that's being entrained. It decreases your effective FiO2. And so when you're thinking of oxygen delivery, your steps need to be to, one, increase the flow rate to match the inspiratory flow rate and increase your oxygen concentration. So how do we do that? There's 4 approaches: standard oxygen, which we'll review, high flow oxygen, non-invasive ventilation, and invasive mechanical ventilation. So this is a chart. On the left, you see the maximum fraction of inspiratory oxygen that you can deliver. And then on the bottom is the flow rates. And kind of the in between the two is the differentiation between a high flow and a low flow oxygen. So standard versus high flow. As you can see, nasal cannula, you can go up to 6 liters. You can get up to approximately 40% FiO2, depending on how much ambient oxygen that patient is in training. If you give them a simple face mask that provides a reservoir of 100% oxygen, or an oxidizer, which is another reservoir, that can help get your FiO2 up a bit more. And then the non-rebreather, which is that huge bag, is a large reservoir of 100% oxygen. So if you increase that flow rate up to 15 liters, you can reach approximately 100% FiO2, which can help bring someone's saturation up. Then if you need to provide even more oxygen, we move towards high flow delivery devices, either high flow nasal cannula, or depending where you practice, perhaps a Venturi mask. And I can tell you that early on in COVID, the WHO actually recommended that we avoid these high flow devices out of concern for aerosolization risk. And in reality, you know, there's very, very scant literature to guide this recommendation. And so subsequent studies, very small cohorts have come out that have looked at the dispersion rate of particles with those on high flow devices. And as you can see, as you increase the flow, the dispersion distance does go up. Meaning if you're on 60 liters per minute of high flow nasal cannula, your dispersion distance of your respiratory particles is 17 centimeters. A Venturi mask, it goes up to 39 centimeters. However, that's not much higher than a cough, meaning that really you're having about the same as if someone's just coughing. So if you have a patient that's coughing with COVID, you can probably put them on a high flow nasal oxygen. And in reality, all of these patients would benefit from negative pressure isolation if you can provide that. So we're going to move on in our case. So this patient is initially managed with nasal cannula. However, on hospital day 3, due to ongoing desaturation, she started on heated high flow nasal oxygen with increasing oxygen requirements. And as you can see by her chest x-ray, she's developing progressive bilateral infiltrates. On hospital day 5, she's saturating 88%. She's on 100% FiO2 and 60 liters per minute. So what would you try next? So we're going to move to our next poll. Would you proceed with intubation for invasive mechanical ventilation? Would you trial some non-invasive, maybe some BiPAP or some CPAP? Or would you add a non-rebreather because you can get a little bit more oxygen?
Just about half of folks have voted. We'll give it another 10 seconds.
All right, so a fair amount of people might actually try non-invasive. So let's review the evidence behind this. Thank you guys for responding. So when you're thinking about non-invasive ventilation versus heated high flow oxygen, I want you to think back, what is the manifestation of the COVID-19 infection? And there are patients who have a condition by which non-invasive has proven efficacy. For example, heart failure with pulmonary edema, COPD exacerbation, or obstructive sleep apnea. Those patients benefit from non-invasive ventilation. And remember, that's considered an aerosolizing risk procedure or treatment. And so you want to have, be sure that there's a filter on your apparatus. However, if a patient has ARDS or pneumonia, the likelihood that they're going to respond quickly or improve quickly over the next 24 to 48 hours is actually quite low. And as I'm about to show you, there's an association of non-invasive ventilation for ARDS, which is associated with harm. And so although it seems like a good salvage therapy, in reality, there's actually some signal that it could be hurting the patient. And so in general, if they truly have ARDS, I would move directly to invasive mechanical ventilation. So as a reminder, the diagnostic criteria for ARDS includes bilateral alveolar infiltrates, and then it's based on your P to F, which is your PaO2 measured on your blood gas, to your FiO2, which is the fraction of inspired oxygen. So if someone's on 100% oxygen and their PiO2 is 68, their P to F is 68, and they meet criteria for severe ARDS. Technically, that patient must be on a ventilator to diagnose that criteria. However, many people assume that heated high flow can provide some extrinsic positive end expiratory pressure. And so in reality, if someone's severely hypoxemic on heated high flow, they likely have ARDS. And so as Dr. Hippenstall alluded to, this process is filled with alveolar inflammation. These alveoli are filled with protein cells and inflammatory markers. And so these things are not going to get better quickly. So what do we know? And this is informed by two very large trials. The first was the Florally trial from New England Journal of Medicine, 2015. They randomized patients with pure hypoxemic respiratory failure to standard oxygen, which was non-rebreather, versus heated high flow versus non-invasive. And the primary outcome was intubation. All three conditions had the same prevalence of intubation, meaning neither therapy prevented intubation more than the other. So if someone has ARDS or pneumonia and they need to be intubated, they will get intubated, unfortunately. However, their secondary endpoint was actually mortality, and patients that received non-invasive ventilation had a higher risk of mortality or higher association of mortality. And if you look at the data, it's probably because those patients with NIV got higher tidal volumes, and we know that high tidal volume ventilation is injurious. Secondly, there's the Lung Safe study, which is a very large international cohort study looking at ARDS practices. They did a subset analysis and they looked at non-invasive ventilation for patients with ARDS. And for those that had severe ARDS, defined as a P to F less than 150 based on their criteria, 47% had NIV failure. And those that failed NIV had a hospital mortality rate of 45%, which is larger than what we expect for ARDS. And so I think based on these two data sets, I would use caution if you're going to use NIV, and I would actually recommend avoiding it. So therefore, you have to think about the timing of intubation because some of these patients can be supported on heated high flow for days, and some never need intubation. However, if someone has rapid progression of oxygen needs, if they have evolving hypercapnia, if they're confused, or if they have hemodynamic instability, I would have a lower threshold for intubation and proceed quickly. And then lastly, you need to think about the availability of your airway support. You know, it's quite dangerous to intubate someone who's setting 85, 80%. They don't have very much reserve and they can often decompensate during the procedure. And so you really, of course, you don't want to do it too early, but you definitely don't want to do it too late. All right, so we're going to move on. So this patient is intubated. She's placed on a volume control mode. Her tidal volume is 500, respiratory rate is 20, PEEP of 10, and FiO2 of 60%. Her blood gas is a pH of 7.3, PCO2 of 50, and a PaO2 of 50. And remember, we want that a little bit higher. Her plateau pressure is 34. So lastly, what are you going to do to her ventilator? And I'm realizing my poll is kind of hard to answer because I have an all of the above to yes or no. The goal is to guide a discussion.
Got about 40%, so we'll give it about 10 more seconds. Okay.
All right, perfect. Yeah, so in general, you want to make all of these changes, and we'll talk about the stepwise management. And so this is really the foundational practice of management of patients who have acute respiratory distress syndrome, and you want to apply that for patients that have COVID. And so we want to practice lung protective ventilation. So you're targeting in a PaO2 of 55 to 80. You want a plateau pressure less than 30, right? Because high pressures in the lungs cause injury to the alveoli, known as barotrauma. Additionally, high volumes in the lungs cause volutrauma. And so we want to target 6 mLs per kilogram, which is predicted body weight, which is based on the patient's height. And so, you know, unless someone is over 6 feet, a tidal volume of 500 is far too big for anyone. And then lastly, we allow permissive hypercapnia, which leads to a respiratory acidosis. And so as long as the pH is above 7.15, you're fine. And so really the first step is to calculate the ideal tidal volume. There's many equations on kind of smartphone apps that can do this. Then you check a plateau pressure via an inspiratory pause maneuver. And if the plateau pressure is above 30, which is on the kind of the flow diagram on the left-hand side, you want to sequentially drop the tidal volume down to mitigate that high plateau. Additionally, you want to be sure that there's no intrinsic PEEP, which can happen in patients who have airways disease. You want to ensure optimal patient ventilator synchrony, so you may need to titrate your sedation. If the patient has severe obesity, sometimes because we think that that external pressure could be raising their plateaus, we might tolerate a higher plat, but in general, I wouldn't do that until you can be absolutely sure. Once the plateau pressure is less than 30, then you can really go up on your FiO2 and PEEP ladder, and we'll talk about why you titrate based on that. So why does lung protective ventilation reduce mortality? So there's 3 types of lung injury: volume trauma, barotrauma, and atelectasis trauma. And if you think about ARDS, it's heterogeneous, right? You look at that woman's chest x-ray, some of her lung is normal. So if we give her really high pressures and we overdistend these normal alveoli, they're going to be injured. The injured alveoli similarly are potential to kind of opening and closing, which can also drive lung injury. And so you want to kind of open the alveoli, keep them open, but not prevent them from collapsing. So you need PEEP to keep your alveoli open, and you need to avoid excessive pressures. Okay, one last poll, and we're going to move on. So this patient's 5 feet tall. So her vent settings are actually changed. So lung protective ventilation for her is a tidal volume of 270 cc's. Her respiratory rate is increased. Her PEEP is increased. Her FiO2 is increased. Her P-plat is now 29. Her ABG is 7.2, 60, and 65. So anything else you would want to do at this point? Do you want to place her prone? Do you want to paralyze her? Would you go up on the PEEP further? Or would you refer her to an ECMO center?
About 45%, give it another 5 or so seconds.
All right, prone positioning, fantastic. Okay, and all of these things are appropriate, but I would definitely encourage trying to place her prone. So how does prone positioning work? So it improves VQ mismatching, or VQ matching, which is ventilation to perfusion. And so the idea is that these dorsal columns of the lungs, this posterior part of the lungs, if you can aerate and provide preferential ventilation and get the heart and the stomach off the lungs, you have less alveolar collapse, but the perfusion is maintained. You improve your compliance of your chest wall, and you improve your distribution of your tidal volume and your PEEP. So physiologically, it makes sense. And then clinically, there's a huge survival benefit. So this is based on the PROCEVA trial, which was a randomized controlled trial in 2013. As you can see, the diagram is on the right-hand side. But in summary, proning a patient for 18 hours a day, if their P to F was less than 150 and they were on more than a PEEP of 5 and an FiO2 greater than 0.6, was associated with a large absolute reduction in mortality. So mortality rates came from the 30s to 40s, which was kind of associated with the lung protective ventilation, reduced down to 16 to 23. And if you're interested, there's a really nice New England Journal video about the proning. What about self-proning? And this is something that we started doing during COVID. There's not great data at this point. It's based on observational cohorts. There's no controls. It's short follow-up, but it seems to improve ventilation and oxygenation, and it's feasible and safe. So if a patient can lie on their belly, you should encourage them to do so as long as it's safe. And it might help stave off intubation, although we can't say that definitively. So additional things that I want you to consider when someone is intubated, and I like to call this kind of the pyramid of evidence for ARDS, or also the P's of evidence. And so at the foundation of the pyramid is this lung protective ventilation based on the ARMA trial in 2000, which reduced mortality from 40% at the time to 31%. Then PROCEVA similarly has the same very large mortality benefit, so prone positioning. Paralysis early on based on the Accurasis trial did reduce ARDS mortality. However, subsequent repeating of that trial based on the ROSE study, which was published in 2009, showed no change in mortality, and it probably relates to our improvement in practices and management. That being said, if someone has severe hypoxemia, paralyzing them can buy a little bit more time. Additionally, people like to titrate the PEEP, and it shows that higher PEEP, so giving someone a little extra PEEP, may be beneficial in moderate to severe ARDS. Pulmonary vasodilator therapy, which is actually pretty early adopted on for many patients with refractory hypoxemia, improves oxygen, but doesn't improve any patient outcomes. And then lastly, I want to touch on ECMO because it's important to think about early. In 2018, based on the EOLIA study, there was a mortality improvement if you sent someone to an ECMO center, although many of those patients didn't actually get ECMO, but it's a high volume mechanical ventilation center, and so they often did a little bit better. And then most recently, I'm sorry, that was the CSER trial. And then most recently, the EOLIA trial showed no mortality benefit, but there was a signal towards benefit with ECMO, and many people think it was underpowered. So when to consider it, if someone has severe hypoxemic respiratory failure and you estimate their mortality risk to be above 50%, you should consider. And then people would say it's indicated if you think their mortality risk is greater than 80%. And that's based on the Murray score, which is on the chart on the left-hand side, which is based on their P to F ratio, how severe their chest x-ray is, what PEEP they're on, and their lung compliance. And so someone who has a P to F ratio less than 100 with kind of multifocal opacities probably should be considered for ECMO if you can look at their likelihood of survival, which is known as the RESP score, which is based on, as you can see, it's a multi-parameter score where you're given different points. The younger someone is, the shorter they've been mechanically ventilated, the type of disease that's causing their respiratory distress is associated with their risk of or their likelihood of survival. So if your RESP score is greater than 6, you have a 92% chance of survival with ECMO. And so if your mortality is much, much higher than your predicted survival is very high, then you should consider ECMO. And so what does the ECMO survival look like for patients with COVID? So this just was published in Lancet on October 10th. And it was based on the ELSO registry, which is the International Registry of ECMO Centers. And their reported survival for patients who needed ECMO is 37%, and so quite good. I think you have to recognize that the cohort of these patients, they're pretty young, right? Average age was 50. And additionally, 31% of them had no comorbidities whatsoever. And so this is a pretty young and healthy group of patients. And so what I would say is you want to think about it early in someone who has single organ lung disease with a likelihood of high survival to consider a referral to an ECMO center. So in summary, as someone progresses with their ARDS due to COVID, you start with standard oxygen therapy, high flow oxygen, try proning, self-proning if feasible. I would skip non-invasive ventilation unless it's clear. Once they're invasively ventilated, think about this pyramid of evidence. The majority of patients should get lung protective ventilation. You should prone them, consider paralysis, consider some PEEP trials. And then if they're very, very sick, think about referral to an ECMO center early. And with that, I will stop and we can answer questions.
Thanks. So we want to go ahead and open it up to questions and welcome you to either unmute yourself and ask your question or enter it into the chat. I have one question here from Sarah Rowan. Should patients who test positive as outpatients check their oxygen saturation regularly so that they can seek care with supplemental oxygen early if they are developing hypoxemia?
I'll start and then Joe, maybe you can add. Yeah, I think patients should. And we, for many of our patients, we try to manage them at home. We encourage them to get a pulse oximeter. I think also based on the discussion last or 2 weeks ago, there seems to be some benefit with corticosteroids once patients require oxygen, similarly with treatment of remdesivir. And so I think once a patient has COVID and they're on oxygen, then they should be treated with some COVID specific therapies as well. And additionally, to mitigate the adverse events of hypoxia. So I would also encourage once a patient is necessitating oxygen, that they should probably be evaluated in person by a physician too.
I think to dovetail with that, this is sort of anecdotal, but I think there's this tendency that people who wait too long, they end up in more trouble. And probably because they're missing treatment options, just like Anna's saying, like they're not being seen by a doc to get the things that we think are effective. And so I think it's very valuable. It would be nice to be able to give pulse oxes from a clinic, because I think as pulmonologists we run into that all the time. But yeah, I think it's very reasonable to be checking regularly.
I was wondering, do you all see the same type of increased mortality in ARDS with obesity, just for ARDS in general? Is this something unique to COVID, or is this something that you see as pulmonologists just in general in ARDS?
So I'll start to answer that. Nana, you may have more data than me, but there's actually an interesting paradigm in ARDS that it's a paradoxical benefit of obesity typically is what's thought. And the thought is that there's sort of inflammatory priming that they don't get as sick. So oddly, I think for obesity in general, there is sort of this weird paradoxical reaction that maybe their mortality is less. That's not proven absolutely, but so in some ways we think that it should be the opposite. That said, I think our COVID mortality rates are probably around 25-ish% is my guess in ARDS, maybe a little bit higher, but sort of matching what we see for other forms of ARDS. I think early on, there are these reports of 90% mortality, 95% mortality with ventilation. And I think that was probably resource limitation more than anything. But I think as we've seen how this disease has progressed over time, probably 20 to 30% is what we're seeing, which may not be so far off from sort of a normal ARDS population.
Yeah, and I would just add, I think that, or like for ARDS in general, like it does seem like obesity might have a little bit of protection, but then for COVID, we are not sure. There's a group out of Tulane that's done an analysis, and based on their cohort trial, they do think that obesity is associated with a higher risk of mortality, but it's very hard to parse that out from the additional medical comorbidities and burden, as well as the effects of kind of the demographic implications and socioeconomic status, which also limits the ability to social distance and kind of these other things that we're seeing associated with severity of disease. And so is obesity a marker of something else? And that's what's driving it? We don't know, but it does seem like there could be an association for more adverse events based on kind of some Tulane research. And they actually have a large grant that they're trying to study this further.
And so we had a question that had come in before you all ever started to talk about proning and its use in folks that are non-ventilated, and what you all have been doing with that, how well it's tolerated, and like how many hours are you actually having these conscious folks be prone?
So I would say at Denver Health, we don't have a formal protocol, but we encourage the patients to lie on their belly as they're able to. And most patients will have some symptomatic relief, and so they'll like it. There are some patients that love it and will stay in prone position for the entirety of the day. They'll try to sleep in prone position. There are some patients that can't tolerate it for many reasons. And so if you look at the cohort studies, they're quite small. They're anywhere from, I believe, like 16 to 54 patients. And they showed that if you were to prone, it improved oxygenation. And then if you were to place supine, oxygenation decreased, and then proning helped. And most people who go from prone to supine to prone again can regain that improvement in oxygenation. There's not great data to suggest that it decreases ventilation or intubation rates yet, as of yet, but people are trying. So we try it. That's kind of our summary. Joe, what do you guys do?
Yeah, I think it's very practitioner dependent for us. Like it's not something, I think we're seeing a lot of people who end up sort of independent of self-proning or not, end up where they're going to end up. And so I think it needs to be studied like everything. I mean, I think this is one of the challenges with COVID. It dropped on us. It looks like ARDS. Everybody wants to do something about it. But in reality, my sense is that treating it like ARDS is the answer. We don't have self-proning data for ARDS. It'll be nice if we get it from COVID, because I think then we can apply it actually to more patients potentially, which is sort of the more interesting and exciting thing for the rest of our lives, and hopefully not just this 1 to 2 year blip. But we use it. I don't say we haven't mandated it by any means.
And I guess I was wondering if you could also tell us a little bit about what you're seeing as regards time on the vent. After somebody requires intubation, what are you seeing as your median times on the vent? And what kind of things are affecting that?
I think at University of Colorado, like I can speak for our first about 120 patients because we did a good review of them. I would say on average, it's 10 to 14 days on the vent. So it's a long course, but that's actually totally comparable to ARDS more globally. So 14 days is a really normal median to mean time on the vent for ARDS, for particularly severe ARDS. Those who we're seeing probably 15 to 20% of patients ending up with tracheostomies that decide to sort of go down that road. And so those patients, you know, we're not offering tracheostomy until 21 days. So that's a pretty typical time for that decision, even though we would usually do that sooner in most of our patients. That said, we've had some patients, I had a patient the other day who went 32 days and ended up getting extubated. So people go a long time. He was young. He ended up doing well, which was really surprising to everybody. But that's sort of the end of the spectrum, I'd say. For ECMO, I would add, again, 30 to 90 days. I mean, I think we probably had a 45-day patient for ECMO.
I was wondering if people could enter into the chat if they have access to ECMO in their facilities or a referral center, just to get an idea of who we have on the line, and then just ask our speakers to give a little bit of what their experience has been at their centers with ECMO. We were talking about this a little bit before we started.
Yeah, while people are entering, I can speak. So at Denver Health, we had, prior to COVID, recently started an ECMO program, but our program is very unique, such that it's run by our respiratory therapists. And so we have 2 RTs who would sit pump. We don't have perfusionists. And so we decided from an equity perspective, because we were having a lot of surge, an RT can normally run between 8 and 12 ventilators. And so we felt that to pull a respiratory therapist to provide care for 8 to 12 people, to prioritize the care of 1, we didn't think that was equitable. So we closed our ECMO program because of that, to really focus on ventilator management. As you can see, the evidence doesn't fully support it. So when there's equipoise, we felt as though we would prioritize best ventilator practices. Therefore, we do refer to the university, and we've sent a couple of patients over. I believe it's about 11 miles away from our 2 institutions.
And I think from the ECMO perspective at the U, we haven't had a ton of patients. I mean, I think, like I said, maybe 5 to 10% of our patients have ended up on ECMO. I think we've had people who are transferred for ECMO. They don't end up on ECMO, sort of like the CSER trial from 10 plus years ago. And I think proning has worked for most folks, but it's a long, it can oftentimes be 7 to 10 days of proning. And so it's sort of that expectation that you're going to go back and forth for a while. That said, we call our surgeons potentially early just to make sure that they're aware and they can give us a yes, no, because sometimes they're going to have absolute contraindications to ECMO, and they may just have this gestalt that that's a patient they don't think they should offer ECMO based upon what they know. We've had young patients, so almost 20 years old on ECMO. We've had 50 to 55-year-olds on ECMO. I think we've sort of hit a hard cutoff of between 50 and 55 years old is sort of where we're offering, dependent upon circuit availability and things like that. So.
Thank you. And so it looks like we only got 2 comments on ECMO. We have one who has access and one that has to transport the clients. We have another question just about steroids at baseline, or getting steroid bursts as an outpatient, and what your sense has been about whether this affects outcomes. I think there might be a little bit of data coming out about Decadron in people who have COPD and whether that helps. If you all have any thoughts about that or have seen any literature on this.
So I defer right now because I'm like hopeful that we have really good data at some point. That I defer to the recovery trial, which is the big British trial that came out, and they've basically put out all of the things that I think are beneficial other than remdesivir, which is really Decadron 6 milligrams. And that's for patients who require oxygen and patients who have severe disease. I think the most benefit is in severe disease. So those who end up mechanically ventilated, really those are the ones who have mortality benefit. Those who require oxygen don't have mortality benefit, but I think they have a decreased hospital stay, if I remember correctly. And actually those who don't have an oxygen requirement are harmed by it. So I think we have to be careful with overprescribing. That's what we know so far. That's, I think, a 900 patient trial, which is about as good as we do in in critical care. So I use those data. I think be careful of giving symptomatic patients who don't have an oxygen need Decadron or a similar steroid. There was a recent JAMA sort of meta-analysis as well. And I think steroids across the board have been helpful, but Decadron is the one that's recommended by the NIH and others. So I would use Decadron 6 milligrams, again, for oxygen requirements or higher. I don't think it's worsened our long-term outcomes for those who are severely ill. And I think in general, you're going to get some benefit. But yeah, maybe there is going to be this when should we stop? Should we stop when they get on ECMO? I'm not sure. I think we're using it even with ECMO.
And then there's a question about what you've seen in your survival rates of ECMO at the university to date.
Anna, do you want to comment on the steroids? I know you, real quick.
Oh, yeah. Yeah, I can say, I don't know about, I'm not familiar with literature that suggests that patients who are on like chronic steroids or who get it for a COPD exacerbation, I'm not sure about those outcomes. I know there's like a benefit, for example, suggested with Flonase, right? People are like, oh, maybe Flonase helps. And, one of our allergists posited that, like if it helps you prevent from touching your face, then you're going to reduce transmission. I think like if someone's healthier in general, they'll probably do better if they've become acutely ill. And so if there's an indication for a condition, you don't think you need to avoid steroids. But at the same time, I'm not sure if there's great evidence that guides us that I'm aware of yet. And then Joe, you want to talk about your survival rates for ECMO?
Yeah, I think, so unfortunately we're collecting those data right now. And I know that our division the CT surgeons have those data. I just haven't seen it recently. My sense is it's about 50 to 60% survival like they're seeing in the ELSO cohort. So, but they're long courses. So I think that's the one caveat is that 90 days on that, the ELSO sort of accumulation of data may not actually represent those super long-term outcomes of patients with ECMO. And so we'll see what happens at half a year to a year because they're very sick patients. They get very deconditioned. I think most of them are ending up in LTACs with trachs. And I think a lot of them are recovering, but we don't know exactly what that's going to look like. And fortunately, we're going to have a recovery clinic where these ECMO patients will come and we'll see what they look like in 6 to 12 months, which is going to be really helpful for us to know how do we sort of counsel patients and families on it.
Well, I'm going to give it a minute here for any additional questions, and then we're going to have to do our wrap up. I want to thank the speakers for excellent presentations, and thank you so much for your impromptu answers to several questions coming in. And Victoria, I'm going to hand it over to you.
Wonderful, thank you. Well, yeah, thank you again to our presenters and to our faculty who are on this call and to those of you who submitted questions. I just put in our SurveyMonkey link, so if you could take our evaluation, it shouldn't take you more than 2 minutes is what the average it's been telling me. That'll just ask you how today went, and again, as always, it'll ask you about what future topics you want to hear about. That is how we help plan these sessions, so we can be nice and responsive to you all. So please take that evaluation. Our next session will be again in 2 weeks on October 27th at the same time, 7:30 Mountain Time or 8:30 Central Time. We will have a few speakers discussing the surge planning during COVID pandemic lessons learned. You can reach out to myself or Caroline if you have any questions or anything. And I just put both of our emails in there. But with that, we would love to thank you all for being here today, and please reach out if you need anything in the meantime.